Sometimes we got nurses that come in here.
This is no time.
Not y'all.
Well, we do. Sometimes.
Thank you, Dawn, for not hitting live stream.
We appreciate that. Yeah. No problem.
It's just painful. Yeah, maybe I do. Take
I'm ready to start. I can go ahead. I'm ready to start. I can go ahead.
Yeah.
Okay. All right. Thanks for joining me this afternoon to talk a little bit about rheumatoid arthritis. My name's Sam Dalvey. I'm an associate professor of medicine at the University of Alabama at Birmingham School of Medicine. I have no relevant disclosures for the talk today. In terms of the learning objectives, I've listed them here. I'll go through each of those. And I think, one of the main things I want to drive home is that rheumatoid arthritis really is a systemic disease that requires a multidisciplinary approach to management and care. So the learning objectives I've listed here are to understand the known genetic and environmental risk factors for rheumatoid arthritis, describe the current theories out there which explain the pathogenesis of this disease, describe both the articular and the extra-articular manifestations of rheumatoid arthritis, understand the diagnostic evaluation of a patient with suspected RA, and then finally, in the context of COVID, I thought it'd be helpful to show you some guidelines or show you where to find guidelines for medication management, the medications we institute for therapy for managing rheumatoid arthritis. The ACR, the American College of Rheumatology, has come out with guidelines, and I'll allude to those at the end of the talk. So in terms of the outline here today, I'm going to talk with you briefly a little bit about the epidemiology of this disease. I want to talk also about disease mechanisms, both genetic and environmental factors that contribute to the disease. The clinical expression of the disease and the clinical manifestations we'll discuss as well. I think it's important to also talk about the appropriate diagnostic evaluation for someone with suspected rheumatoid arthritis and when it's appropriate to refer to rheumatology. And then finally, we'll talk about treatment considerations for patients with rheumatoid arthritis, both pharmacologic and non-pharmacologic interventions. So a little bit about the epidemiology of this disease. So the epidemiology, the prevalence of rheumatoid arthritis is considered to be roughly about 1%, and it's important to keep in mind that varies with certain populations. So among certain Asian populations, the prevalence may be a little lower at 0.2%, whereas in some Native American populations, the prevalence is closer to 4 to 5%. The prevalence increases with age, and it's about 2 to 2.5 times greater in women than in men. The peak incidence of this disease occurs generally between the 4th and 6th decades, and we do know from several defining studies that there is a genetic predisposition. Monozygotic twin studies have shown a concordance rate as high as 30% in some studies. And in terms of the clinical course of this disease, this is an older graph that I wanted to share with you that shows that rheumatoid arthritis kind of follows several trajectories, and the most common clinical course is more of a polycyclical course where patients may have episodes of increased disease activity and flare that's treated appropriately, and then they go into remission for a certain amount of time, and then they may have flares later down the road. It's important to keep in mind that in a minority of patients, it does tend to follow more of an active disease where patients continue to have active inflammation. There are more joints involved, and that can lead to permanent joint damage. Some predictors of more aggressive disease, which we'll talk about a little bit later, are the presence of rheumatoid factor, the presence of nodules, and other extra-articular manifestations, which we'll talk about. This is a graph that I wanted to show you that is a bit dated, and I think if it was reproduced now, the lines would be a little bit different, but I wanted to show this to illustrate that mortality in rheumatoid arthritis is related to disease severity and certain comorbid factors, and on average, the median age of death is about 4 years younger than in control populations. And some of the predictors of outcome include gender, systemic disease, patients with extra-articular disease that we mentioned earlier, radiographic presence of erosions, and the presence of rheumatoid nodules. So you can see here the probability of survival plotted against time that compared to the general population, patients with rheumatoid arthritis, in particular those with extra-articular manifestations, whether that's kidney disease, lung disease, neurologic disease, the probability of survival is less compared to the general population as a function of time. When we're talking about disease associations and genetic risk factors, the risk of developing this disease in first-degree relatives is about 1.5-fold higher than the general population. And the most potent genetic risk for rheumatoid arthritis is conveyed by certain MHC alleles. And so we know there is an increased prevalence of RA associated with a subset, the DR4 and DR1 HLA alleles, and that gets to this hypothesis of the shared epitope. So several HLA studies, typing studies, have shown that a conserved amino acid sequence is overrepresented among some RA patients, and that sequence maps to the third hypervariable region of certain DR alleles and beta chains. And the presence of this shared epitope is associated with both increased susceptibility to and severity of rheumatoid arthritis. Oops. So different models have been proposed to explain the role of the shared epitope in rheumatoid arthritis, and some of these hypotheses include the following here. So the presence of this shared epitope, some people posit, may allow for more efficient binding to potentially arthritogenic peptides. It may lead to inadequate numbers of regulatory T cells, which can help control the immune response. And some people think the shared epitope may become the target of T cells due to molecular mimicry. Some alternative hypotheses have been also offered, and that includes the association between that shared epitope and the presence or the production of certain autoantibodies, anti-cyclic citrulline antibodies. Some people feel this shared epitope, one theory is that the presence of this shared epitope confers a positive charge to the peptide binding cleft on certain MHC class II molecules that prevents binding of peptides containing arginine, which we'll talk about how arginine plays a role in the citrullination process, which people think is one of the pathogenic mechanisms in rheumatoid arthritis. This is just a table showing some of the major genetic factors associated with RA, and we've talked about the shared epitope. I just wanted to highlight two others here, seen here with the red arrows. There's a protein tyrosine phosphatase called PTPN22 that some people think may contribute to an increased genetic risk by leading to increased citrullination of certain proteins that then may trigger an immune response. The other one I mentioned here, I've highlighted here, is the peptidyl arginine deaminase, or PADI for short, and that's an enzyme that catalyzes the conversion of arginine, an amino acid, to a different form called citrulline. And some people feel that some of these enzymes may lead to increased citrullination, which increases risk for development of rheumatoid arthritis. So we've talked about genetic risk factors. I wanted to talk a little bit about environmental risk factors, and I don't want to focus as much on bacteria and viruses, but just recognize that there have been some studies and theories in the past that certain infections with bacterial agents or viruses may increase risk of development of rheumatoid arthritis based on, again, that concept of molecular mimicry, and some of these viruses or bacteria having similar proteins, homologous proteins to some of the alleles that we discussed previously. What I really wanted to focus on, though, is the role of tobacco. There have been enough studies now which show that patients who use tobacco are at a higher risk for development, or tobacco use is associated with an increased risk of developing rheumatoid arthritis. It's not completely clear. You might wonder about other forms like vaping or e-cigarettes or dipping. Those forms haven't been shown to be strongly connected with development of rheumatoid arthritis. It's really more inhaled or tobacco use, smoking, that's been associated with as a risk factor for development of rheumatoid arthritis. Here is a table again which just shows some of the environmental factors associated with rheumatoid arthritis, and as I mentioned, one of these is exposure to tobacco smoke. It's important to note that a lot of these factors have conflicting associations, and so they've only been studied in small studies or single studies. But I think it's fair to say that exposure to tobacco smoke is it's well described, and most people are fairly convinced that is a risk factor for rheumatoid arthritis. In terms of the opposite, decreased risk, fish consumption and omega-3 fatty acid consumption has been shown to be associated with a lower risk of rheumatoid arthritis. Okay, changing gears just a little bit, I wanted to highlight briefly some of the pathogenic mechanisms as it relates to rheumatoid arthritis, and I've kind of broken this down into three components, so the autoimmune response and inflammatory response, and then talking briefly about mechanisms of joint destruction. So a little bit on rheumatoid factor. So what exactly is that? So rheumatoid factor is an autoantibody against the Fc portion of normal immunoglobulins. Most commonly it's an IgM that's directed against IgG. It can be present in up to 75 to 80% of patients with rheumatoid arthritis, and can also predate the diagnosis of its detection it can be detected prior to clinically apparent rheumatoid arthritis. It is associated with more severe articular disease, so more severe synovitis and radiographic severity. It's also associated with rheumatoid nodules and extra-articular features as well. One important point I want to mention is that there are other things besides rheumatoid arthritis associated with the presence of an abnormal or elevated rheumatoid factor, and those I've listed here that we can talk about. So other autoimmune diseases, namely Sjogren's syndrome and lupus, can be associated with the presence of rheumatoid factor. Chronic infections is important, so hepatitis B and C, subacute bacterial endocarditis, and other infections like tuberculosis can also be associated with development of rheumatoid factor positivity. Certain pulmonary diseases, so patients with a autoimmune lung disease called sarcoid can have detectable rheumatoid factor. It's also important to note that healthy patients, so up to 4% of young patients, and then over age 60, up to 20 to 25% of patients may actually have the presence of rheumatoid factor in the blood without any clinically apparent evidence of arthritis. And then finally, I mentioned certain forms of malignancies, in particular lymphoma, can have rheumatoid factor as well. Here's just a table from UpToDate that shows the more common non-rheumatic diseases associated with rheumatoid factor, and you can see the conditions here on the left column, and then the frequency of detectable rheumatoid factor as a percentage. And some of these numbers are fairly significant. You can see with endocarditis or hepatitis B or C, the frequency of rheumatoid factor can be up to 50 to 75%. Pulmonary diseases, so sarcoidosis up to 33%, and then certain malignancies, up to a quarter of those can be associated with the presence of rheumatoid factor. Another important concept in terms of the understanding the humoral response to rheumatoid arthritis is understanding these anti-citrullinated peptide antibodies, and we call them Ccp antibodies, or ACPAs for short. Those can also predate the onset of clinical rheumatoid arthritis. They're associated with a more aggressive disease course. They can be present in up to 90% of patients with RA. It has been demonstrated that smoking can increase the risk of developing these anti-citrullinated peptide antibodies. In general, they're relatively specific for rheumatoid arthritis. Some of the newer assays have specificities up to close to 90% for rheumatoid arthritis, but I think it's also important to understand that the generation of these antibodies can be seen in other disease states. So I've listed a few of those here for you. So spondyloarthropathies, diseases like psoriatic arthritis or ankylosing spondylitis in that group, autoimmune hepatitis, and then in terms of infections, TB, tuberculosis can also be associated with CCP antibody production. This is just a slide showing the process of citrullination. So as I mentioned before, citrullination is a process where certain enzymes called PADDs take arginine here on the left and convert it to a different type of amino acid called citrulline. One of the theories, again, is that, take for example smoking. Tobacco smoke can cause, some people think can cause increased upregulation of some of these enzymes, which can target certain proteins, that allows some of those proteins to be changed, some of the residues to be changed from an arginine residue to a citrullinated residue, and that change to citrulline serves as a tag that can lead to loss of tolerance and enhanced inflammation, which, if unchecked, can lead to rheumatoid arthritis. A little bit about, that was B cells that we talked about. In terms of T cell autoimmunity, T cells are implicated in rheumatoid arthritis due to the presence in the synovium of patients with this disease. And several models have highlighted the role of T cells in both the development and the progression of certain forms of experimental arthritis. And in one mouse model, mutation in a signal transduction protein that's associated with the T cell receptor signaling can cause arthritis through thymic selection of certain arthritogenic T cells. And it's been demonstrated that CD4 T cells infiltrating the synovium display more of a Th1 phenotype, which we see in rheumatoid arthritis. In terms of the inflammatory response, macrophages and fibroblasts are the main sources of cytokines in inflamed synovial tissue. And these cytokines participate in enhancing synovial inflammation. The main ones that I wanted to list today are tumor necrosis factor, interleukin-6, and interleukin-1. Studies in RA patients have showed increased levels of these cytokines in serum. In terms of mechanisms of joint destruction, I wanted to talk a little bit about the steps involved. So the first one I've listed here is angiogenesis and cell migration. So inflammatory cytokines can induce the expression of certain receptors on capillaries that help to regulate and facilitate migration of inflammatory cells in the synovium. In terms of synovial pathology, it's really important to understand that the synovium is the primary site of inflammation in rheumatoid arthritis, and I'll show you some pictures of that shortly. Subsequent to that, there's extracellular matrix damage, and that's manifested by both cartilage destruction and bone destruction. And in terms of the former, that's it's thought that synovial cells release destructive enzymes, and I've just listed one here as an example, matrix metalloproteinases, MMPs, which contribute to damage to the joint. And then bone destruction, which is primarily caused by osteoclasts and mediated by a certain type of ligand called receptor activator of NF-kappa B, so call that RANKL for short. Over time, if rheumatoid arthritis goes unchecked, it leads to synovial inflammation, which can cause formation of pannus, and that's the term that's applied to that synovial hypertrophy here. And you can see here in this picture is a picture of this pannus that's invading down into the cartilage and causing destruction. This is from a young patient with rheumatoid arthritis. And this is a picture of that pannus formation in a patient who had a joint replacement. Sometimes this pannus gets very extensive and can break off and proliferate in the synovial fluid that when you aspirate it, it can look almost like little pellets of rice. Okay, bringing all this together, this is just a figure showing the concept of development of rheumatoid arthritis. So in a person who is genetically predisposed, who has the presence of certain genes, whether it's as we discussed, the shared epitope in conjunction with certain environmental factors, and they've listed several here, some that we didn't talk about. We talked about smoking, but there's also increasing interest in the role of oropharyngeal disease as it relates to rheumatoid arthritis. It's known that certain bacterial pathogens, oral flora, can lead or contribute to citrullination through those enzymes that we discussed earlier, those PADI enzymes. Again, genetic susceptibility in the context of certain environmental factors with other potential modifications can lead to loss of tolerance, production of certain autoantibodies that can lead to an inflammatory response leading to symptomatic arthritis. Here's just a figure showing on the left what a normal joint looks like, and then the cartoon on the right is a joint that's been damaged due to rheumatoid arthritis, and it's really just meant to show you some of the main mediators here on the right of a patient with rheumatoid arthritis. You have osteoclasts, T cells, B cells, other cells, along with angiogenesis, contributing to this heightened inflammatory response. And then going a little deeper within the synovial tissue itself, this just highlights some of the targets for which there have been developed therapeutic targets now, which have been very effective for rheumatoid arthritis, and I'll just point out a few here. So tumor necrosis factor and IL-6, there are medications we can use now to target those cytokines, which can lead to decreased inflammation and improvement in symptoms. So what are some of the clinical manifestations? Changing gears a little bit about what are some of the clinical manifestations for rheumatoid arthritis? Well, as many of you know, it's a symmetrical polyarticular joint disease that leads to progressive joint destruction and loss of function. The symptoms in general last more than 6 weeks before considering this diagnosis. Usually there's some chronicity, and patients can have symptoms for several months before seeking help. One of the defining features of rheumatoid arthritis is stiffness, so morning stiffness that tends to improve as the day goes on, which the stiffness can last an hour, 2 hours, and improves with the patient starting to become ambulatory and moving more. There's palpable synovial swelling, which has almost of a spongy feel to it. And again, as we discussed, there's the presence of certain antibodies, rheumatoid factor, autoantibodies, rheumatoid factor, and Ccp antibodies. And a lot of patients also have constitutional symptoms. They just may not feel well. They may have a lot of lethargy and fatigue. These are some of the more common clinical manifestations. Here's a picture just showing evidence of some of that synovial swelling, which if you were to palpate that would have almost a boggy feel to it. In terms of joint predilections in patients with rheumatoid arthritis, this disease typically, at least initially, involves smaller joints, although larger joints such as the knees can be involved early on. But it typically involves the smaller joints, so wrist joints, metacarpophalangeal joints, PIP joints, and then smaller joints in the feet too, so the ankle joints and the MTPs. It typically spares the thoracolumbar and SI joints, the former in part because there's due to absence of synovial tissue there. It tends not to involve the distal interphalangeal joints or the IP joints of the toes. So here's a picture of illustrating a patient with rheumatoid arthritis in the early disease phase. And again, very commonly there's symmetric synovitis in these patients involving the wrist joints, the MCP joints, and occasionally the PIP joints as well. And so this is a patient who has had rheumatoid arthritis, or has had symptoms suggestive of rheumatoid arthritis for about 2 months at the time this photograph was taken. Seeing things like this now is thankfully should be more the exception rather than the rule, thanks to the medications we now have to treat rheumatoid arthritis. You may see this, these types of hand deformities in patients with well-established disease who may have had it for 30 years prior to the advent of very, very strong medications to treat the disease. But thankfully, we do not see this commonly anymore. And these, what this is meant to kind of illustrate is just chronic rheumatoid arthritis can cause damage with subluxation of some of the hand joints that leads to ulnar deviation. This is a patient who had some sort of surgery here of the Metacarpophalangeal joints. This is a patient who, you can see, has rheumatoid nodules on several of the fingers with both swan neck and buttonhole deformities that you've probably heard about or read about previously. It's also important to note that rheumatoid arthritis can affect periarticular structures as well, and so it can cause bursitis. This is a patient who has olecranon bursitis related to rheumatoid arthritis, and you can see here the very prominent swelling over the olecranon and an associated rheumatoid nodule as well. And as I mentioned earlier, the presence of these rheumatoid nodules is associated with a higher risk of more severe disease activity and worse outcomes. These nodules can occur anywhere. They tend to occur more on the the extensor surfaces over pressure points, so the arms, the forearms here, the feet. They can also occur in unusual locations too. It's been described they can occur within the dura and on heart valves as well. This is, I think, an important slide, and I think it's really is meant to just drive home the point that rheumatoid arthritis can very commonly have extra-articular manifestations. So, we in rheumatology don't worry just about the bones and the joints. We also worry about extra-articular manifestations, and you can see here this cartoon shows some of the other organs that are affected by rheumatoid arthritis. So. Just for example here, the eyes causing inflammation can contribute to scleritis. Lung disease is common, and we'll discuss that as well, manifested either as effusions or fibrotic lung disease. It can also affect the bone marrow and cause, in some cases, cytopenias and leukopenia. And then it can also affect, in long-standing disease, the nervous system and cause peripheral neuropathies and mononeuritis multiplex. This is one of these extra-articular manifestations is inflammatory eye disease, and episcleritis can be associated with rheumatoid arthritis, and patients can oftentimes have this red eye that occasionally can be associated with pain with episcleritis. And so it's really important to make sure that patients with rheumatoid arthritis who have eye symptoms or ocular symptoms, it's important to get them established with an eye specialist and ophthalmologist to further evaluate for the possibility that they may have ocular disease related to RA. Interstitial lung disease in rheumatoid arthritis is becoming more and more appreciated, and many studies have shown that patients with RA, up to a third of patients with rheumatoid arthritis can develop lung disease. And again, this can be manifested by lung nodules, pleural inflammation, so pleuritis, pleural effusions, and also interstitial lung disease. And where I practice, there's a multidisciplinary clinic that's involving where pulmonologists and rheumatologists work together to identify patients with rheumatoid arthritis with concomitant lung disease and work together to treat not just their joints, but also treat the underlying lung disease as well. And oftentimes that involves just being aggressive and trying to optimize their RA regimen. And one of the patients who on examination may have rales, that may be due to tobacco use in patients who've used tobacco for long periods of time, but it's also important to consider the possibility that they may be developing or have evolving interstitial lung disease, in which case pulmonary function tests or a high-resolution CT scan of the chest may be helpful. And you can see some of these changes here in a patient with pulmonary fibrosis here, and then on CT scan here, the picture on the left, you can see some of those fibrotic changes with honeycombing illustrated. We've kind of talked about this previously, but again, just to reiterate some of the some of the factors which lend themselves to more of a poor prognosis in rheumatoid arthritis. So earlier age at time of symptom onset, extra-articular disease manifestations, high levels of rheumatoid factor and CCP antibodies, and elevated baseline SED rate and CRP levels. So when you're seeing a patient in clinic and you suspect they may be developing rheumatoid arthritis, how do you think about that? How do you proceed accordingly? Well, I've listed here some of the initial laboratory studies that we usually order, and that includes CBCs and chemistries and rheumatoid factor, CCP antibodies, to see if there's any evidence of seropositivity. Other serologies is clinically indicated if you're concerned if a patient has symptoms suggestive of rheumatoid arthritis but also has dry eyes. Sometimes patients may also have another autoimmune condition called Sjogren's syndrome, so testing for certain antibodies like the anti-Rho or anti-LA antibody can be indicated at that point. And then also checking for the presence of systemic inflammation by testing for acute phase reactants. So we oftentimes order sedimentation rates and CRP levels as well. It's also important to consider obtaining radiographs. Admittedly, early in the course of disease, there may be minimal or no changes, but if patients have had symptoms for quite some time, months or years even, then there's value in obtaining radiographs to see if there's any footprints or markers that could indicate changes due to rheumatoid arthritis, and I'll show you a picture of those. Some of those include joint space narrowing, periarticular osteopenia, where the bones have a washed out appearance, and erosive changes. And if you are fairly confident a patient may have rheumatoid arthritis, obtaining a baseline chest X-ray and then pursuing a hepatitis profile and PPD or T-spot would be warranted as well in someone in whom you're contemplating or has a good chance of needing biologic therapy. This is just a picture of showing the progression in the same joint over the course of many years in a patient with rheumatoid arthritis. This is the Metacarpophalangeal joint, and the picture, the panel on the left, is supposed to show a joint that's relatively normal. I think this picture was taken in someone who either, I think prior to the diagnosis of rheumatoid arthritis, who may have had the presence of autoantibodies but no clinical synovitis. And then the middle panel is someone 6 months after the disease has been established, where you can see an erosion here at the margin, which is very suggestive of rheumatoid arthritis because that synovial capsular lining is right there, and that synovium, as I mentioned, is the first site of inflammation, and so it tends to target areas around the margin of the joint first. So you can see that erosion right there at the margin. And then over time you can see increased joint space narrowing, or the bones are almost touching. So there's diffuse loss of cartilage with significant joint space narrowing. This I wanted to show you, up until about 10 years ago, we used an older classification criteria scheme for rheumatoid arthritis. This is from 1987, and while the sensitivity was pretty good, people realized there were faults with this criteria. In particular, one of the criteria here at the bottom, this radiographic changes on hand and wrist radiographs. So erosions, and that implies chronicity, that the disease has been going on for some time. So you can see the fault there, that we, in order to make a diagnosis, we were using criteria that where permanent joint damage had already been established, and so a revision of this criteria was introduced about 10 years ago by both the American College of Rheumatology and EULAR, the European equivalent, where the focus or emphasis was on earlier diagnosis. And there's a scoring system here that you can see from 0 to 10 involving the number of joints, the serologic profile, the duration of symptoms, and then the presence of acute phase reactants. And so a diagnosis of RA here is a score of either 6 or greater. And so, the focus of this revision was to really try to diagnose people earlier, sooner, in order to initiate therapy appropriately with the goal of hopefully controlling joint inflammation and preventing permanent joint disease, permanent joint damage. So when you're seeing a patient in clinic with joint pain and swelling, it's important to consider other diagnostic possibilities, and I've just listed some of the other ones here that I think it's important to think about. So in terms of other arthritides, ones to think about include gout, pseudogout, and some of the seronegative arthritides. A lot of times you can make the distinction between rheumatoid arthritis and gout and seronegative arthritides based on historical features and a predilection for certain joints. Gout typically involves the lower extremities and the first metatarpsophalangeal joint, the big toe. Seronegative arthritis, there may be other features, rash, psoriasis in the case of psoriatic arthritis, or an antecedent infection in the case of reactive arthritis, or significant GI symptoms in the case of IBD-associated arthritis. So a lot of times historical features and a proper examination can tease those out. Pseudogout can sometimes be confusing because it tends to occur in older patients, and one of the slides I showed is that older patients may have the presence of a rheumatoid factor, which may not be contributing to their joint disease. So sometimes that can be difficult to tease out. Radiographs can sometimes be helpful, or aspirating a swollen joint and demonstrating the presence of those calcium crystals, which could indicate pseudogout, can be helpful as well in trying to differentiate between rheumatoid arthritis and one of these crystalline diseases. It's also important to mention fibromyalgia as an entity in the differential diagnosis. That's a chronic pain syndrome that is not an inflammatory syndrome, and it's not an arthritic condition. It's not due to inflammation or damage to the joints. It is thought to be due to increased sensitivity, and their lab work that's done typically doesn't show any evidence of rheumatoid factor or Ccp antibodies, and acute phase reactants are oftentimes normal. There's no clear evidence of synovitis or joint swelling in patients with fibromyalgia. They oftentimes will describe allodynia, where something that shouldn't cause something that should be innocuous, a hug or something, can cause pain that's out of proportion to the pressure applied. Oftentimes these patients can have tender points on physical examination and can have other features such as poor sleep hygiene and fatigue and depression. And so thinking about that, you can oftentimes make a distinction based on a thorough history and physical examination when considering some of these differential diagnoses. In terms of the goals of rheumatoid arthritis therapy, when a primary care physician or a specialist is concerned, based on historical features and examination and lab work, that someone may have rheumatoid arthritis, certainly referral to a specialist is appropriate. Starting DMARD therapy as early as possible is important, and for physicians or APPs who are not rheumatology who are not specialists in rheumatology, one of the first treatments that can be instituted are anti-inflammatories like non-steroidal anti-inflammatories or even corticosteroids at modest doses to help alleviate symptoms and to bridge them until they can get in to see a rheumatologist. Now I mentioned here minimize use of steroids. I think it's important. Steroids can be a very effective therapy for treating rheumatoid arthritis, but as most of you know, chronic steroid therapy is associated with many problems and adverse effects. So it's important to try to taper patients off corticosteroids if they've been initiated on therapy, and use DMARD agents, which we'll mention here briefly, as a bridge, using steroids as a bridge while we institute DMARD therapy to help control the disease. The goal, the aim should always be for remission or low disease activity state. It's important, and we'll talk about this towards the end, to recognize and treat coexisting illnesses. I think that's an area that that rheumatologists are not as good at, is thinking about other comorbidities and making sure that we address and risk stratify appropriately. And then coordinating care related to the previous point is coordinating care with other clinicians. So again, because this disease can affect the lungs, because it can affect the heart and put people at risk for cardiovascular disease, it's really important to make sure there's a collaborative effort and that we all try to work together to help these patients. In terms of RA treatment, I just have one or two slides because most non-rheumatologists are not going to be prescribing the majority of these agents. And so but I did want to briefly discuss some of these. So when you think about therapy for rheumatoid arthritis, you can think about traditional DMARDs, so disease-modifying anti-rheumatic drugs, or biologic DMARDs. And so some of the more traditional DMARDs are medications which we use initially when a patient comes to us with a new diagnosis of rheumatoid arthritis. So methotrexate, sulfasalazine, hydroxychloroquine, leflunomide, and prednisone. Sometimes primary care physicians will feel comfortable instituting some of these medications like prednisone or hydroxychloroquine or sulfasalazine, and I think that's a reasonable good start until they can get in to see a rheumatologist and we can determine if they need more aggressive therapy with some of these biologic agents. And you can see here there's a list that targets different cytokines. So now we have a very large armamentarium to treat and control rheumatoid arthritis medications, which really have been game changers for treating this disease. And so you can see here medications which target TNF, tumor necrosis factor, etanercept, infliximab, adalimumab, then other medications that have been approved as well. So anti-IL-6 therapies such as tocilizumab, JAK inhibitors, T-cell inhibitors which target co-stimulation such as abatacept, and monoclonal antibodies such as rituximab, which target B cells, certain B cells. This is just a picture showing guidelines, a table showing guidelines for monitoring treatment of patients with rheumatoid arthritis. So, for patients who are on these medications, but either they've missed rheumatology appointments or they have seen a rheumatologist, but that person has left. If they remain on such medications, this kind of gives a nice outline of some of the toxicity monitoring labs that are important as it relates to some of these medications. So, oftentimes patients who are on methotrexate or leflunomide or sulfasalazine, we recommend every 3 or 4 months obtaining a CBC, hepatic function panel, serum creatinine, and an acute phase reactant such as CRP. So that can be very helpful in terms of monitoring patients for any potential toxicities. The last few slides, I just wanted to touch on areas which I think we as rheumatologists need to do better, and this kind of relates to this multidisciplinary approach where primary care physicians and other physicians can can help in the management. So in terms of rheumatoid arthritis and metabolic bone disease, a lot of studies have shown there's an increased risk of bone loss and fracture in patients with rheumatoid arthritis, and the prevalence of osteoporosis among patients with rheumatoid arthritis is up to 2-fold higher compared to age and sex-matched controls. RA patients have a up to 30% increased risk of a major osteoporotic fracture and 40% increased risk of hip fracture. Some of the risk factors for developing some of these complications of metabolic bone disease I've listed here. So systemic inflammation, so patients with uncontrolled disease activity, we think can cause production of certain cytokines that can lead to increased bone resorption and put people at risk for fractures. Glucocorticoid use, again, that's one reason out of many to be judicious in using corticosteroids for managing rheumatoid arthritis, because we know that bone loss is increased in patients with chronic doses of glucocorticoids. Disability, which leads to reduced physical activity, which can, less weight-bearing exercise can also put people at risk for development of metabolic bone disease, and low body mass is another item here. Rheumatoid arthritis and cardiovascular disease is important as well. Most patients with rheumatoid arthritis don't die of rheumatoid arthritis. Their highest, the factor which leads to highest mortality in these patients is cardiovascular disease. And so it really is important to think about and address that. So rheumatoid arthritis patients have an increased risk of CAD compared to the general population. There was a panel from the European League Against Rheumatism, where rheumatologists had recommended CV risk scores, some of these Framingham risk scores, be multiplied by a factor of 1.5 in some patients with rheumatoid arthritis to account for that increased risk. And RA patients are less likely to receive both primary and secondary CAD preventive measures. And so I think that's really important, that where primary care physicians or cardiologists can help work with rheumatologists to address that need, making sure that patients have adequate primary or secondary CAD prevention measures. And I know there's been a lot of controversy and there's some debate about use of certain medications for primary prevention of cardiovascular disease. And I think more studies are ongoing will help shed light on that, but it's really important to try to have a conversation with primary care physicians and cardiologists about appropriate therapies as it relates to coronary artery disease. Just one last point in the context of COVID. I think the American College of Rheumatology has done a really nice job of creating a document where they provide clinical guidance for patients with rheumatic diseases. And the link is at the bottom of the slide, and it's only a few pages, and I think it gives a nice framework and pretty good advice about how to think about adjusting or holding medications in patients who either have been exposed to a patient with COVID or have become infected with SARS-CoV-2 or who have COVID. It gives a nice kind of outline of which medications it's thought it might be worthwhile holding until they recuperate, and then which ones, and the timeline about when to potentially resume those medications. So if you get a chance, take a look at that at your convenience, and hopefully you'll find it helpful. So just some last, for the last slide, just some final thoughts. In terms of the future of RA, I think many rheumatologists hope that one day we'll be able to use precision medicine to help guide or inform us in terms of therapeutic interventions. I don't think we're quite there yet in terms of that technology, but being able to identify which patient would have a good response from one particular agent versus another based on testing or the presence of a certain cytokine profile might actually be very helpful moving forward in managing patients with this disease. Again, I want to highlight the importance of an earlier diagnosis, and as it relates to that, after that diagnosis is established, instituting aggressive therapy to try to control symptoms. I think it's always important to work with patients on dispelling myths about this disease and dispelling myths about side effects of medications. I think there's a lot of misinformation out there, and I think taking those extra few minutes and talking with patients about the disease and expectations can be very helpful. As I mentioned before, addressing comorbidities is extremely important, and I think that's important for not just rheumatologists, but again, other specialists working together to try to target and address hypertension, address cardiovascular disease. I think making sure everybody's on the same page is the right thing to do. And then finally, counseling again, always counseling on. I didn't include this here, but tobacco cessation as it relates to this disease. Some studies have shown that patients who develop rheumatoid arthritis and are smokers, if they stop smoking, there's at least one study which suggests that their disease activity may improve. And then counseling on exercise and diet too, non-pharmacologic interventions, which are really important in treating this disease. And that's all I have. So thanks for joining in, and I hope you have a good rest of the day and stay safe.
Or I'll just send Kathy in here and she.
Till they're ready to tell you.
You can start whenever you're ready. We're ready to go. Anyway.
All right, hi there. Today we're going to talk about fractured families, domestic violence 101. The definition of trauma is that it's an experience that produces enduring and emotional pain and distress. When individual trauma results from an event or series of events or set of circumstances, it can be as physically and emotionally harmful as a life-threatening illness. So SAMHSA looks at it as an adverse event that affects individuals' functioning. So how do we as healthcare providers address that? So before I get going, we're going to talk about my disclosure, which is my husband and son own a medical device company. I am a funded researcher, and I have an additional disclaimer. This is actually lifted from a government site that should protect me from anything that anybody says I've done in this. I do want to point to you that I'm using all my photographs come from Creative Commons, and I don't intend to infringe on any copyrights here, but rather to illustrate educationally what I'm trying to prove here. So here's the objectives. And there's one other that I want you to know. I'm not responsible for your learning. What you do with what I say is up to you to go to the literature. So, the objectives today are based on what I presented last year, so I do recommend that you go and view that. It'll be some repeat, but I hope to now look at DV in the environment of COVID and what does it mean? What are the roles and theories in epidemiology? What is that guides our practice? But more importantly, how do the systems respond in a trauma-informed way? So how do we create safe environments for people? What does that look like? And on the UAB Clinical Pearls website, I have a 30-minute webinar on trauma-informed care. So you can really do a deep dive into what it is that you want to do when you encounter patients who've been victimized. So we're going to talk about a lot of symptoms in the presentations and medical interventions, but more importantly, we're going to talk about how to objectively document so that when you are called to court as a witness, that you do not stumble over your biases. So, Lenore Walker conducted a study way back in the 70s, I believe, and the result of that study came from a theory. And the theory is there's a cycle of violence that's predictable, and it explains how and why the behavior of a person who commits the domestic violence may change so dramatically. Doesn't show that face to the outside world, but what happens in the intimacy of a relationship and what does that look like? So it's not the same for everyone. People have different methods to gain control over another individual. In domestic violence, it can go as far as isolating the person. That's kind of minor, but they usually find a way to get out with their friends, all the way to toxic environments that they don't even know how to turn around in the day because it may create this aggression against the individual. The offender's methods, however, are typically predictable. So if they strangle, and they strangle other family members too. When they choose to exercise this anger, they won't do it in front of anybody. So that says to me, as a provider, they can control themselves. Okay? So think about it like that. And many times they will say it was a punishment, something that they broke the rules, and the rules may be totally unknown. So 40 years ago, our relationship understanding is evolving. So let's look at the Duluth Model, which was developed in the 70s. Very little has changed except the use of the popular world today, male privilege. It's now turning into gender privilege. Eventually it will be resting on behavior. So what it boils down to is one person has physical or emotional advantage over another. And since the majority of the arrestees are assigned to the masculine or male side, you think it's all males. However, while I use male in my talking and female victim in the vernacular, I want you to know that there are some female and feminine gendered persons who are the aggressors in the relationship. In fact, in my own personal life, the first domestic violence I was exposed to was the wife throwing hot grease on the husband after she hit him in the head with a cast iron skillet. He spent a lot of time in the hospital. So when you look at that, then it becomes the behavior. Had it been the other way around, male to female, it'd been easy to identify. But not so easy when females do it, okay? Because then you get people saying, oh, they were defending themselves. Really? With hot grease in a skillet? Okay, think about what that means. So we know the physical, sexual, and emotional violence between persons is not a gender issue, but rather a behavior issue that uses threats and coercions, intimidation, targeting emotional weaknesses in the person, like, I love my children, they're gonna hurt my children, or my animal, or my family. So in order to do that, the aggressor has to isolate and deny and blame and minimize the protests of the victims. So when they do that, these actions are known as gaslighting. So the victim ends up thinking they're crazy, that really isn't as bad. It must be something they're doing wrong. And when successful, the aggressor gets in the way. As nurses and physicians, we look at the medicine, we look at the biopsychosocial elements, but let's look at the methods that are used to control another. So the victim, I'm going to, again, the victim could be any gender, but it may be a female. Maybe if the couple's LGBTQ plus, maybe a minority. It doesn't matter, but the aggressor, let's look at the first phase. It's attention building. Victim feels angry, unfairly treated, hopeless, tense, afraid, embarrassed, humiliated, disgusted, and even after a while depressed. The behavior directed against them may be tense, frustrated, disgusted, self-righteous, jealous. Their behavior, the victim's behavior, becomes more nurturing, more submissive, more walking on eggshells, very afraid to express feelings, and may use alcohol and drugs to avoid the situation. The partner, on the other hand, the behavior is verbally abusive, escalating fits of anger, silent treatment, controlling, somewhat arrogant, very possessive, demanding, irritable, and it may worsen with drugs and alcohol. Phase 2, this is when the violence happens. This is what the woman's feeling: frightened, trapped, helpless, even numb. Her behavior may try to protect herself or hit back or submit helplessly, maybe to seek a way to get help. Often we'll counsel women to get into a protective physical position so that her head and gut and heart are protected. So the partner then becomes more enraged and angry and has a righteous, jealous, or frustrated feeling, but that behavior is dangerously violent, has deliberate desire to hurt or kill, becomes out of control, blaming, of course, the victim, irrational, almost like the character of Dr. Jekyll and Mr. Hyde. Robert Louis Stevenson was really onto something, wasn't he? So let's talk about after the violent event. It's remorse. Used to be called honeymoon. It's cooling off. The victim is relieved, pretty angry over the incident, resentful, feeling guilty, wondering why she couldn't perform to prevent this event, and in denial about the seriousness of the physical, mental, or emotional assaults. This is when they come in the emergency department with injury and they'll offer excuses for the batterer. They may try not to talk to you about it. They try to solve and prevent future incidences, and they hope and believe that the changes they promised during this time will change. At this point, the partner, realizing that they are almost going to be caught, is apologetic and remorseful and forgetful about the degree of violence. It really wasn't that bad. Self-righteous, unable to understand why the woman is still angry. Their behavior is they make promises to change, blame her or others for the problem, and may use alcohol and drugs. Now here's the kicker. First time I saw this really happen was a woman who ended up with a lacerated liver, broken ribs, and a carotid dissection. And he brought to her a diamond ring that was so heavy, and her room was full of flowers. And she said to the police, "I'm not interested in pursuing this." So you see, there are a belief system that OMG, he's going to change. He promised me. Look at all the things he did for me. And then I've got to ask rhetorically, is he going to change? So consistent definitions are really important for data collection for us to understand this. So the terms and definitions are standardized and they're listed here. Remember, domestic violence is the willful intimidation, physical assault, battery, sexual assault, abusive behavior. It's part of that systemic pattern of power and control. It's perpetrated by one intimate against another, where sex and gender do not matter. Okay, it is the aggressor and it is the victim. So when I can help you start seeing that this is a behavioral issue and not a gender or sex issue, it is about the behavior. So it's prevalent in every community worldwide. And regardless of the age or socioeconomic status, orientation, race, religion, nationality, it doesn't matter. It happens when you have the characteristics that we talked about. I think that what I'm kind of teeing this up for is think about during COVID-19 and the isolation that occurs and the stresses that come with the isolation, loss of job, loss of support systems, etc. Let's take a closer look at the incidents in the literature. Methods include sabotaging, hurt and humiliate. Look, he's going to check your phone, your email, social networks without your permission. He's going to go in and look at the balances in your bank account. He's going to control your birth control. He's going to make sure that the condom breaks if you ask him to use it. He decides what you're going to wear, where you're going to eat, how you spend money, and he will discourage you from going to work. Again, I use the he as a catch-all because that's the majority of arrests. He's going to humiliate you in front of others on purpose. He's going to destroy your things. He's going to threaten to hurt you and your children and your loved ones. And he blames you for the violent outbursts. So when this happens and you hold him accountable, it may actually be that he is still controlling. So let's look at what the CDC says. And this is a video, so I'm going to start it, right? And let's hope this works.
Intimate partner violence is defined as physical violence, sexual violence, stalking, and psychological aggression by a current or former intimate partner, and is preventable.
Intimate partner violence threatens the well-being of millions of people.
Is it coming out on your side, Dawn? Can they hear it on the video, though? Yes?
I was hearing it. I can't even see the PowerPoint anymore.
It's coming back.
There was, but I can't see the PowerPoint
It's
anymore.
coming.
Perfect. Now let's try it. Let's try it again.
Intimate partner violence is defined as physical violence, sexual violence, stalking, and psychological aggression by a current or former intimate partner, and is preventable.
Intimate partner violence threatens the well-being of millions of people and their families every single day. Intimate partners may include current or former spouses, boyfriends, girlfriends, dating partners, or sexual partners.
Intimate partner violence can occur between heterosexual or same-sex couples. Some victims may suffer just one experience, while others endure violence that lasts for years.
1 in 4 women and 1 in 9 men have experienced intimate partner violence in their lifetime. And 1 in 10 high school students have experienced physical teen dating violence, which is a form of intimate partner violence.
Intimate partner violence consequences are widespread.
It impacts physical and mental health. It results in billions of dollars in medical, mental health, and lost work productivity costs.
But the good news is that intimate partner violence is preventable. We have strategies that can help you prevent this problem in your community. We can prevent intimate partner violence by teaching safe and healthy relationship skills, engaging influential adults, working to prevent violence starting in early childhood, creating protective environments, strengthening economic support for families, and supporting survivors to increase safety and lessen harms.
So, if it's preventable, then my question to you is, how do you intervene? So who does this? Abusers tend to, in the literature, have a higher consumption of alcohol and illicit drugs. An assessment should include questions that explore drinking habits and violence. They're possessive, they're jealous, they're suspicious and paranoid, so they may demand to stay with their partner. They may be controlling in all kinds of everyday activity, finances, but they suffer very low self-esteem, and they have an emotional dependence that tends to occur as a symptom in both partners, but more so in the abuser. So what are the risk factors? Let's see what the literature says. It says it's multifaceted. It says there's an inverse relationship between education and violence. The more education one has, the less violent they are. Childhood abuse increases offender behavior. So a person who has experienced childhood abuse may copy the same methods in the family, and then they repeat it with every new relationship. It's often learned is a reasonable way to resolve conflict with those you care about. Of course, drug and alcohol abuse increases, but remember, abuse is learned from family, community, and culture. Sorry, let me go back one. So let's look at what happens in the United States. Average 20 people experience intimate partner violence every minute. That's more than 10 million abuse victims annually. 1 in 4 women and 1 in 9 men. We don't know the numbers in persons in the LGBTQI community. Sexual violence is a component, intimate partner stalking, and the results are PTSD, fearfulness, injury, anxiety disorders. And because of the risk behaviors in this individual, they may bring home sexually transmitted diseases. If we understand this part of it, then it makes us understand that as much as 35% of what comes in our emergency department is directly related to domestic violence. 10% of women and 2% of men have been stalked. 1 in 10 have been raped by the intimate partner. 1 in 12 men have been too. So the data is unavailable for the most part on male rape, domestic violence, etc. But we'll see them in the emergency department. They come in as victims of battery. So we look at this again, and we've got the same numbers. This one is from the CDC, and you'll see the numbers vary. And a lot of that depends on the data set that they use, but it's pretty consistent. 1 in 7 women, 1 in 25 men have been injured, which means that a bunch of those are going to show up in your emergency department and in your ICUs. We recently saw where a woman with her child ran into her partner's car and killed the child. So you see, aggression occurs in a lot of locations. Gender doesn't matter. So pre-COVID-19, what does it mean for healthcare providers in a COVID-19 period? Well, there are no studies on that. We will have some data at some point in the future when we do some retrospective work. However, there was a 2019 study about Hurricane Harvey that hit Texas and ran up through the middle of the country. What they found was it increases stresses in families that were directly related to interpersonal violence. Job loss, strained financial and loss of social support systems, and fewer options for safety and finding help because the system was shut down in the hurricane. So if a person and children are stuck at a home with an abuser who's under financial and job loss strain, what can systems do to eliminate the insecurity by providing housing, food, and employment during a time when we're all quarantined? I often say in my age group, I was grounded, that was the word that was used, for a good part of my teenage years. So quarantine's not a big deal for me. But for those who have never had to restrain their activities, this is very stressful. There's a lot of similarities between the Hurricane Harvey and what's going on during COVID-19. So pre-COVID, 7 million women, 5.6 million men experience rape, physical violence, and stalking by an intimate partner. And the injury, of course, we talked about it. Again, this is from a number of researchers. And these researchers focus on the women, but we are just starting to realize the complexity in domestic violence. And now we're going to be looking at men and how men respond to the aggressor who is their partner. So I will tell you that Hucker and Smock, Bill Smock, reported a national rate of non-fatal domestic violence is declining. Okay, but what's happening? It's actually thought to be due to a decline in the marriage rate and decreased domesticity is what they call it, better access to domestic violence shelters, improvements in female economic status, and an increase in the average age of the population. Because there is a maturing out of addictions, there's also a maturing out of violence. You find out that it doesn't work real well in life. So there's opportunities for collaborative approaches to address the struggles that teens and young people have so that they can have a fuller, richer, intimate life with a partner that they choose. Now, I've put this on the adverse childhood experiences because I think it's one thing that informs us about what's happening to the kids. So Kaiser Permanente study back in the 90s, mid-90s, 17,000 middle-class people enrolled in that system. And what they found was that the more events a person has in their lives as children, the more likely they are to die significantly earlier than others. This is an important study. The CDC has a big website on it with lots of research. But what I want to bring to you today is that when we look at the abuse issues, what we find is that the data says that emotional, physical, and sexual abuse is probably one of the worst things that you can do to a child. Neglect is part of that. And when the original studies were published, there were only 10 items, but today there actually are 12 or 13. And one of them has to do with social determinants of health, and that is neglect, and it is about unstable housing. So what do we have during COVID-19? Loss of income, unstable housing. So when children are in the military and they move every year, or when parents have children from apartment to apartment to apartment through no fault of their own, but their jobs change, they may be migrant workers and things like that, then we know that these children will have a lot of the same health outcomes. What mitigates that? It's going to be that one individual person that they can point to as adults, a teacher, a relative, a significant other, and it is unconditional love and acceptance that comes from that person that allows that child to see hope and overcome the adverse experiences. So when you think about that, I'm going to challenge you to go to the hope literature so that the persons who come to you who are very ill, and by the way, this is an amazing slide because it talks about the lasting impact, the development of coronary artery disease, the development of depression and anxiety, unwanted pregnancies, increasing fetal deaths, risks to these women, HIV, STDs, cancer. I was invited recently to a cancer seminar where they were talking about the violence in the background of cancer survivors and those who live after treatment and those who succumb to the cancers after treatment. When there's alcohol and drug use and abuse, there's unsafe sex and rape. And then, of course, the education, occupation, and income has a significant part to play. I put this chart up here because the chart is a compilation of studies that stress the pathophysiology of stress, which is DV is one type of stress. And in this case, the CDC reports that the negative health outcomes associated with DV affect a range of conditions that begin with the heart, digestion, reproduction, muscle, bones, nervous system, all of which are chronic in nature. They're the big 5 diseases that we see in our hospitals. So if they have depression, if they have stress disorders, it makes sense then that they're going to pick up on behaviors like binge drinking, overeating, smoking, risky sexual behaviors. That's what the data tells us. So why would they pick up smoking? Well, believe it or not, when the vagal nerve gets going, and it's in one of these boxes in here, the vagal nerve stimulates hormones to be released, and the heart responds. So one of the things we teach patients to do to relax is to take a deep breath. So when they smoke, they take a deep breath. The difference is that you still get a vagal nerve response to the deep breath, but now you're putting poisons in your lung. And when you don't tease that apart, it's really hard for somebody to give up smoking when they have a nicotine addiction when you tell them to deep breathe. Okay? They're not going to be able to do it. David McCollum, a physician colleague of mine at the Academy on Violence and Abuse, went to the literature in 2014 and he identified all these diseases that are stress-related diseases that you see. You're not going to be able to read it, and I apologize for the small print, but this is actually online under Colviva, and it will set you back because guess what? Stress-related diseases are what we're seeing in our hospitals. So how do we apply stress-related theory to domestic violence, and in particular during COVID? So what we're looking at is a stress response is to a challenge, a problem, or a threat. We know that if we're healthcare providers because we've all taken a test without studying. So we know that stress response. The hormones trigger a cascade of physiologic changes in our bodies, and occasional and brief stress is not a problem. However, when it is prolonged, severe, chronic, it can cause significant problems. I co-authored a paper on coercive toxic stress in human trafficking and why the difficulty in overcoming stress is so great. And it has to do with never fully realizing that you have nowhere to step without a consequence to that action in a domestic, intimate relationship that's violent. So it causes an adverse reaction in our bodies, and when we're children, that I don't know of any study that says children escape a domestic violence family without at least one mental health disorder, and it's called stress reaction. So they are going to have an anxiety syndrome and not fully understand it or know how to abate it. So what is toxic stress? When you're in a continued situation, like in COVID-19, with an aggressor, toxic stress causes a flood of hormones that forces you to end up in an exhaustion phase using Cellier's stress theory that I went into last time. And that exhaustion, you can never fully recover from it. So what does that mean? Well, it actually eventually affects your immune system, and it has very long-lasting and negative consequences for your cognition, behavior, immune functioning, and ultimately your physical health. So there's a lot of research going on around this now, trying to find out what were the stresses and what do we need to do to mitigate those stresses in that person's life. And there's going to be some things we can do. Remember, CDC says it's preventable. Sorry, I went too fast. So let's talk about some of the more, and we're going to do a deep dive here, because when a person is pregnant and under significant stress, the research says that they will develop preeclampsia and hypertension prevalence will go up from 8 to 22% versus 7% without the stress. So when you look at your at-risk women who are pregnant, it makes sense that you would investigate what are the stresses in your life, because you want to be able to mitigate those stresses to help them learn how to do the relaxations that we know work. Deep breathing's one of them, thought diversion's another, exercise, eating well, taking your vitamins. When you look at historical stress, that is the epigenetic changes that occur in families because of war or a number of generations that have been aggressors in domestic violence, then you're going to see that this population will suffer more health outcomes that are poor. Does that make sense? Okay. When you have 325,000 pregnant women per year report DV, if we're not documenting that in the record, we are setting that infant up and we're setting up the mother for long-term problems. What we have is emotional abuse, physical abuse, sexual abuse, and sexual coercion, and I'll deep dive into this a little bit more, but basically they impregnate without consent and they sabotage birth control methods. Hide them, replace them, do all kinds of things. I've even known women who've had their IUDs ripped out that have actually, in Africa, they ripped the wombs of women out in the civil war in the Congo. So this happens, be aware of it, and the woman you may be seeing may have been a victim of that. So let's talk about sexual coercion a little more. It's unwanted sexual activity. You're pressured, you're tricked, you're threatened, and you're forced. It can make you think that you owe sex to this aggressor. It might be from someone who has power over you, like a teacher or a landlord or boss, but in this context of domestic violence, it's going to be your intimate partner. And I want to emphasize, no person ever is required to have sex with someone else, ever. So what is he going to say? I want you to figure out the category here. Here's some examples. If you really loved me, you'd do it. If you really loved me, come on, it's my birthday. You don't know what you do to me. You already got me all worked up. You just can't make somebody stop. It was perfect. Why do you want to ruin it? If you don't have sex with me, I'm going to break up with you. Everyone thinks we already have, so we might as well. And if you don't, I'm going to tell everybody anyway. I'll make it worth your while. You know I have a lot of connections. If you don't do it with me, I'm going to do it with your child. I totally respect your work here. I'd hate for anything to change that. I haven't yet decided who's going to get bonuses this year or what I'm going to get you for Christmas. You work so hard, it's the same shame for you not to have a good grade. And if you don't do this, I'm going to out you. Could you see where it fits under the examples? And these are things that have been said to me by patients. So what is sexual coercion? And yes, when does it become rape? Well, against your will is rape. Say no, it's rape. If you're drunk, it's rape. If you've been drinking, it's rape. You can't consent in any state if you're under the influence. I have to tell my husband that, okay? Think about that. When the symptoms of sexual coercion are there, it's because they come in for an STI, maybe have HIV or AIDS. They may have healing anal and vaginal tearing that was related to the rape, but they're not calling it a rape. They just said it just hurt. Painful intercourse, pelvic pain, infertility, obviously. Low self-esteem. We've got to do the work to evaluate for homicide, suicide risk. What if there's an unintended pregnancy? How are you going to support them then? What about adolescent? Where are the support systems? And what happens when they want an abortion, a therapeutic abortion? What happens when it's a spontaneous abortion? And the list of researchers identified here are the ones that are studying this, and it is ongoing. So think about it in terms of the more we understand, the more we know, the more we can prevent and mitigate what's happening in our patient population. So let's look at strangulation, because I'm going to tell you, and I didn't put it in here, but a man who strangles non-fatally his partner, or a woman who strangles, and it's non-fatal strangulation, has a 700% likelihood of being involved in a police shooting or a mass killing. This is on the website for Strangulation Institute out of California that are doing a significant number of studies. So 1.5 million women are strangled. Manual strangulation makes up 80%. And of those, a ligature is only used in 15%. Pretty much all strangulation victims are female because it's a physical strength kind of thing. Most strangulations occur at home. Only about 10% seek medical attention. Now, why is that important? Because the ones that we see, we're thinking, oh, well, their voice is not raspy, they're conscious, they're able to talk about it. But let's look at it. Keep this in mind every time somebody says they were choked or strangled. 6 to 10 seconds, they're going to pass out. Seconds. That was determined by Rawson in 1943 when he studied persons hospitalized in a mental health institution. Would never go through IRB today. What we know now from the emergency departments and first responders, it takes 30 seconds to be without oxygen, and you're going to need to revive them. They're going to lose bowel and bladder. If you're a nurse, you've seen that, and you know that you're in trouble because 30 seconds have gone by. At 1 minute, without oxygen to the brain, it is a point of no return for most. Not all, depends on your health, your age, your status. At that point, you'll see a minor seizure. At 4 minutes, the brain is dead. So you don't have much time. And I will also tell you that when the eyes fix, the EEGs show delta wave changes. And the eyes fix in the first 10 seconds. So I'm going to give you this. This is really important. This is also on the Strangulation Institute. Post it in your ERs and on your floors so that you recognize what it looks like. The woman on the right is courtesy of San Diego Police Department trial files. It was adjudicated. She presented in the top picture at trial. At the hearing, first hearing, she looked like the second picture. At trial, she looked like the third picture. Think about what we saw in her first picture. We saw blotching and redness and swelling. But it wasn't till later we saw the bruising conflate, and it wasn't till she was completely healed that we saw what she really looked like. So how are you going to address this? First of all, ask her, do you look like this regularly? Have you got a picture of yourself? Because I'm seeing some things I'm concerned about, okay? Tips for screening. Provide a very safe place. Interview her, non-threatening, confidential. What I try and do is I respond to them. Most nurses get a sense about how their patients are. Are you in a relationship with someone who threatens or has hurt you in any way? How about today? Is that why you're here today? I noted you have a number of bruises. Can you tell me how this happened? Did someone hurt you? There's controversy about apologizing, saying it's not your fault, that kind of stuff. Just be sure don't load your baggage onto them, okay? So confidentiality. Let's talk about the guy or the girl who has to stay with their partner throughout the interview. Find a way to get them away from them, because safety is a huge deal, especially as it relates to trauma-informed care. And for those of you who can bill, here are the strangulation billing codes. Asphyxiation, and by the way, asphyxiation occurs with a knee on the neck. It can also occur in a headlock. It can also occur with hands. It can occur one-handed, two-handed, one-handed with an arm, with a knee. There's a number of ways this can occur. And we've seen it recently, making change, thank goodness that it doesn't go for naught, making changes globally. So the S codes describe the injuries to a single body part. The T codes describe injuries to an unspecified part. But you know what? This is the thing you have to know, is that carotid artery dissection, while rare, must be evaluated to avoid malpractice. If you have a car crash where a seat belt injured the neck, you do a CT scan with contrast. And you don't find it very often, but occasionally you'll find a dissected carotid. In women who are strangled, this is the poor outcome. So here is a discharge sheet. Say the person wants to go home. Here is a discharge sheet that will absolutely protect the organization. But remember, there's a sample discharge for patients who complain of this. Many times they'll just say, oh, he just put his hands around my neck. He chokes me till I pass out. Listen to the descriptions in their language, okay? Because it's likely you're not going to see injury. Most women don't have injury. When they come in with injury, it was a serious non-fatal strangulation. Hoarseness, petechiae in the eyes, petechiae on the face, swollen face, muddle-headed, can't remember. All of those things are a part of that. it helps you know how serious the injury is. The neck will continue to swell over 24 hours. Okay, so ultrasound may be an option if you detect edema after measuring the neck. In an hour or two later, it's getting bigger. Okay? I think the form also lets the patient know the seriousness of their injury because they typically go home. They go home to the person. So let's look at what they tell us. So I'm going to start this one again. Are we ready for the video? Hopefully it'll work. And it's about 11 minutes.
When domestic abuse occurs, many people ask, why does she stay? Others, they ask a different question.
Why did you do it?
Ooh. Wow. I've never thought of that question or the answer.
We were both in the same like intramural after school kind of group called Peer Helpers.
I did this really embarrassing church lady impersonation, and she told me my zipper was down. I was jealous. I didn't like her hanging out with certain people or talking to guys. If we'd ever get into a fight, I would beat up my car.
As a teenager, you can kind of romanticize a lot of that, and you can say, you know, oh, he loves me so much that he just doesn't even want me to, you know, talk to anyone else. He just wants me all to himself. And you can romanticize that into thinking it's a good thing, and instead of seeing it for what it really is.
I would call her names
He called me a bitch every day
several times a day.
for years.
And I punched the wall right beside her head.
The implied message when he hits a wall is, this could be you. That whole thing of wait till your dad gets home if they did something wrong meant something in our family that was very different. It meant they would be terrorized.
She had a job, a third shift job, and I wouldn't come home and take care of the kids. I'd make her do it after working all night and not getting any sleep. No one knew. No one had a clue that I was like this at home. I was the nice guy next door kind of thing.
Which then when he calls you crazy and tells you you're crazy and depressed, you begin to think, you know what, maybe I am doing something wrong because he is so nice to everyone else. What must I be doing to make him act that way? How horrible must I be for him to be like that? Several times through the years I tried to get a job and hide some money so that I could get out. Except he always managed to know how much money I should be bringing home and managed to find ways to spend it before I ever got a chance to hide any of it. And that feeling of not having anywhere to go except to be a burden on others is really, it weighs you down a lot, makes it really difficult to leave. We were at a point in our relationship where I was just done.
And we had been arguing, and I could just tell by the way she came in the bedroom that something wasn't right. And I asked her if she wanted a divorce.
Yeah. He says, you want a divorce? I said, yeah, I do.
For the next half hour, I started to interrogate her and scream at her.
He accused me of cheating on him.
Who is he? What's his name? And accused her of having sex with a woman. Maybe it wasn't, maybe she wasn't into me anymore. It was a woman.
There doesn't have to be someone else for me not to want to be with you.
And as she got up to leave, I, in one step, went from here to about that chair and put my fist through the bedroom door.
And picked me up off the floor and threw me onto the bed.
Not just pushed her, I literally airborne threw her on the bed.
And he's yelling at me and I'm crying and I'm trying to get away and I can't. And he gets on top of me and says, you know, maybe I'm not fucking you right. Maybe I'll do it right now.
And acted like I was going to rape her.
And he didn't. Somehow I got out from under him. I don't even know how I did. And I ran downstairs. I just got away from him as much as I could.
So after a few days and we actually were together, I said, listen, I really think you're depressed. I really think you're bipolar or something. You need to go and get some help.
And I didn't really believe him, but I thought, fine. He's probably right. I'm dealing with all of this stuff. I think I probably am depressed.
She sat down with a woman who probably talked to her for less than 5 minutes and realized I was the one that was being abusive.
This is not your problem. This is him, and I know this place, and he should go there.
April comes home, and she says to me,
you know what? It's not me. It's you. If you want to save this marriage, you go.
Here's the number for Advance. This woman says you need to go there.
He was trying really hard to discredit her so that he wouldn't have to call.
I was like, right, this woman probably hates men.
You know what? She said you'd say that.
I was like, well, she's probably gay. She's probably a lesbian.
She said you'd probably say that.
What really brought me to Advance was to have them agree with me that April was crazy.
I told him I was trying to fix the relationship because I wanted him to get help. Because I knew that he was always going to have contact with our daughters, and I didn't want them to have someone like him for a role model of what relationships were supposed to be like.
During orientation, they showed a video of this guy from Duluth, Minnesota, who went through a similar program, talking about physically punching or headbutting his partner, making her nose bleed. I'm like, man, that guy is an asshole. And then he starts talking about, there were times where I would throw things around the room or break stuff and, call her all kinds of names. And I just went, whoa, I've done some of that. So if he's punching his partner or headbutting her and that's wrong and he's an asshole, I can't say that what he's doing there isn't wrong. So that must mean he's still an asshole for those actions. And that must mean, what am I?
It took quite some time for me to believe that he was really changing, that it was for real, because so many times I heard, I won't do it again, I'll be different, and it was hard to believe that he actually was. And so I tested him too. I would bring up topics like money or family or housework.
I would say the most difficult thing for me going through Advance was early on, it was to drop her stuff. So it doesn't really matter what April does or doesn't do. I'm still in control of my own actions and my own reactions to whatever happens, whatever situation comes up. And listen to what April had to say. Listen to how my actions affected her. And some of that was really difficult. Some of it came at me with some anger in it. And I had to listen and take that as that's really how it is for her, not just, oh, you're trying to make this worse than what it is. Believe her.
So he kept going to Advance, and I was seeing him changing.
After I was going through Advance, she came to me. She's really upset. She's crying.
And I said, when you get home from work, we've got to talk. I got to talk to you about something.
And she's like, I have this $300 cell phone bill.
Is that it? It's just a cell phone bill. I thought you were telling me you were done. You were leaving me. It's just a cell phone bill. You figure this out. Don't worry. And I was so shocked because this would have been really ugly before.
I do really remember the feeling of connecting with how upset she was over it. I must have been horrible to live with if you're going to be crying like that because of a cell phone bill.
I thought you literally crawled around the hallways of the dorm rooms asking for donations. It was... Anyway, that's not what you do.
I heard hawk.
I heard hog. Hog.
You know, if I had a time machine and I could go back in time, the only thing I would want to do is change the way I treated people. Because I would have such a better life, so much better memories. My kids would have better memories. My wife would have better memories.
You're under the table.
I think people often talk about being married to their best friend, and I think it's pretty cool to actually be able to say that I am. I know he's embarrassed by what his behavior used to be like. He's not like that anymore. Can't imagine being that person anymore.
Those things that I did to April on that day and every day prior to that day in our relationship, those bells are still ringing and they still have consequences every day. Why did I do it? No one said that's not how you behave. That's not okay. No one I respected. April would say, you know, don't do that again. And I do my few weeks or a couple of days of trying to straighten out. But because I didn't have somebody saying, hey, no, that's not how you should be in a relationship. That's not how you should treat somebody else that you say you care about.
So we have an example of how an aggressor can recognize the behavior and choose to change. There's a lot of work involved in that, as you can imagine. So let's talk about the physician and nurse factors and why we turn our backs on persons experiencing domestic violence. Well, I think that we think it might open a Pandora's box or can of worms. We don't want to offend the patient. Maybe it's too close to comfort. We have those experiences ourselves, and what happens in Vegas stays in Vegas. We also have this notion that maybe she could leave if she wants to, or she always goes back, so why should I spend the time? I will tell you that there are different models, descriptions of how healthcare providers respond to couples, and that's paternalistic. I decide for you, you do what I say, or it's the highway. Not much better than the aggressor. I give you the facts, you're sharing information, let them do with what they want. Deliberative model, in addition, I let you know what my preference is for you, but your preference doesn't matter. And of course, the interpretive model, I'll give you the facts. Let's find it together. What are your preferences? The last one is patient-centered. So ACEP has specific recommendations, and I covered them last year, but there are medical services, medical schools, emergency medicine residencies that should include education and training about recognition, assessment, and intervention. Dr. Bill Smock, who is one of my colleagues and mentors, works heavily with medical schools to teach them about domestic violence. Excellent speaker also. ACEP opposes mandatory reporting. However, we say that they oppose it. However, we still need to, in hospitals, healthcare organizations, screen for it. Also, we have to ask the question about children, because children involvement in domestic violence sets them up for a pattern of behaviors that we know from the ACE studies will affect their health in the long term. So let's spend the time to do what we need to do to support the individuals as they are leaving. Now, there are trauma-informed care principles that are strength-based, and SAMHSA has tip 57 that I introduced to you last year. And it's important that we address it from a strengths-based approach in the primary, secondary, and tertiary prevention models. Because what we know from the research is that it promotes the physical, psychological, and emotional safety of that patient and gives them back the power that's been taken away, so that they can make decisions that are there in their best interest, because they know their culture, they know their family's responses, they know that they can make a decision about themselves better than we can. And I reflect back of my patients who protected me by not allowing me to go to their homes in a home visit because there were things going on in the home. So, you know, DV screening is a universal patient-centered trauma approach to everyone. It really starts with healthcare workers first. So patients during a routine history taking, now JCO and some other accrediting organizations require it. And if you're going to have magnet status, that's also required. But please do not screen in front of the partner. So trauma-informed is a safe environment, non-threatening, confidential. And those questions, again, are really important, and you need to practice them. Are you in a relationship where you feel safe? Do you feel threatened at any time? Have you been hurt in the past? I notice you have a number of bruises. Are you safe to go home? Would you like my help? Because that probably is the best open door for them to return when they would like your help. So HIPAA always applies. The clause related to record release, related to an active police investigation, is that you must release that record. And so if you make them go after a warrant, they'll do it, but the HIPAA is very clear that if there's an active investigation, that the record will be released. Okay, so the trauma-informed encounter, you're not alone, you're not to blame, those kinds of things. I'm sorry this happened to you is a real good introduction. You look significantly injured. Although it's soft tissue injury and you won't be hospitalized, it looks like it really hurts. Those are the kinds of statements to say. So when a patient tells you nothing's going on, I fell down the stairs or I fell against something, be sure and use photography to document in the record very objectively, and I'm happy to tell you that there are a number of photography protocols out there that you can use. If they continue to deny and you still suspect abuse, it's not reportable. They're an adult. They have all the rights and liberties guaranteed by a Constitution. But document objectively those physical findings. And don't sanitize your documentation. Just name it what it is. I will also tell you that there is mandatory in Alabama, which is where we are, because vulnerable adults, child abuse, and client in danger for self or others with suicide are all reportable. So do know what those laws are. And I show you this slide. It's awful hard to read, but trauma-informed care requires collaboration of many, many organizations. It is extremely expensive, and the Praxis organization is a resource for communities who want to develop a coordinated community response. Originally based on the Duluth Model and prosecution of DV in the 80s and 90s, this citation is on this slide. I will tell you, in Birmingham, Alabama, we're fortunate to have one place. I also have slides in the former presentation about that, and the organization, the YWCA, that supports women who are in need of their services. So, if you're called as a witness, don't worry, you're a witness to the medical evaluation and treatment only. And that's governed by your license to practice. Likely you're going to be asked about what the wounds were and their seriousness. and whether or not you created safety planning. Was your planning in response to that? Did you counsel them? Did you give them the appropriate follow-up information? If there was a reportable event, did you report it? I would also recommend that you inform the mother about the impact of domestic violence on the abuse issues, impact of what she's going through or he's going through on the children. It's something for them to think about whether or not they want to remain in the relationship. So with that, I want to thank you for your attention, and I'm going to open it up for questions. Okay, and so at the end of this presentation, there are a number of slides with references for your library, and I'm happy to be available if you have questions that are more personal in nature. And I'm at the University of Alabama at Birmingham School of Nursing, where we have the best nursing school around. Thank you very much.